We've had a lot of speakers speak to Massachusetts, and now we're going to have a group here to talk about Massachusetts experience plus some other observations. And we have a panel here of three folks. You have their resumes in front of you, but let me just give you a quick thumbnail. First speaker will be Nancy Turnbull. Nancy is a senior lecturer in health policy in the Department of Health Policy and Management and the Associate Dean for Educational Programs at Harvard. And her research interests include health insurance, regulation, healthcare access, consumer participation in managed health plans, and international applications. And before she came to Harvard, she spent 10 years as the first deputy commissioner of health policy for the insurance department. Our second speaker will be Brian Rossman. Brian is the research director of Healthcare for All. I think we're having Brian second, right? The leading advocacy organization dedicated to expanding access to quality, affordable health care in Massachusetts. Before joining this group, Brian was a policy associate at the Snyder Institute for Health Policy at Brandeis. He also served as a research director and general counsel for the House Staff Committee on Health Care in Massachusetts and several other adventures. And our last speaker will be Merrill Matthews. Merrill is the director of the Council for Affordable Health Insurance, a Washington, D.C.-based research and advocacy organization promoting free market health insurance reforms. He's also a visiting scholar with the Dallas-based Institute for Policy Innovation. He is a policy analyst specializing in healthcare, Social Security, welfare, internet issues, and is the author of numerous studies in health policy, as well as several other adventures that you'll read in his bio there. So without further ado, Nancy, you're up.
Thanks. Well, good afternoon, everyone. I'm delighted to be here to share the experience that we've been undergoing in Massachusetts the last couple of years with passing and implementing our health coverage expansion law. We've been following very carefully from up north the progress that you're making here in New Jersey, and very delighted to see you making progress and looking forward to more. I want to say before I start telling you about the Massachusetts law that I've been really delighted today to be on a program that has talked about health systems in other countries. That's really quite unusual in my experience traveling around talking about the Massachusetts law. I myself grew up in Germany and England and have also lived in Canada. And it's very nice to see this trend in the United States to actually think that we can learn something from other countries. So this has been great today. I want to start off by saying that I come here today from Massachusetts with great humility. I haven't come to tell you that we have developed a model for New Jersey or for the United States. Actually, when you're from Massachusetts, you learn that you should not assume that the policies, particularly the social policies that we adopt in our state, will be popular anywhere else. And I learned that very early on because in that great divide that Len talked about between Philadelphia and San Francisco, actually all of my relatives live in Missouri. And so whenever I discuss, which I also learned long ago not to do, politics or social policy with any of my relatives there, one of us quickly has to change the subject. But I did discover when we passed this law that there was something a little bit different about it. And this happened when I was talking to one of my uncles whom I love dearly, but with whom I've never agreed about any political issue. And I was kind of describing the law to him at Christmas dinner, which first of all gives you some indication of how boring our family get-togethers are, that's what we talk about. But I described it to him and he goes, gosh, Nancy, I think that you are no longer communists in Massachusetts. And I thought, gosh. I kind of muttered under my breath, I sort of wish we were, but he didn't hear that. And he sort of looked at me and said, nope, you're not communists anymore, you're only socialists. So anyway, as Senator Vitale said, every single state is different, and as Professor Reinhardt said, we started this discussion in Massachusetts with better preconditions than many states have. As Professor Reinhardt said, we're a relatively rich state, and we have a very expansive Medicaid program. We have a much higher rate of employer-sponsored coverage in Massachusetts than in the country as a whole. Nearly 3/4 of employers in our state provide coverage compared to what's now, I think, about 60% nationally. We have long believed more than many other states in regulating the health insurance market, although I'm in one of the states that shares that distinction with us. And we've also had a very well-funded safety net. And we have been very successful as a state at taking advantage of legal but creative mechanisms under the Medicaid program to bring lots of money into Massachusetts. We also have, as Len joked, a relatively small number of people who are undocumented in our state compared to border states like California and Texas. All of those factors have contributed to giving us what nationally is a relatively low rate of uninsurance. So a couple of years ago when we started this discussion, somewhere between 9 and 10% of people in Massachusetts were uninsured. Our law came about through a confluence of factors, some of them political, a big one of which was, although he hadn't declared it at the time, there were strong suspicions that Governor Romney was going to run for president. We had the renewal of the waiver under which we operate our state's Medicaid program, and the federal government was threatening to take away nearly $400 million a year from our state, and I can tell you nothing sharpens the attention of the state legislature like thinking that you're going to lose that amount of money. We had wonderful organizing and advocacy from Healthcare for All, the group that Brian belongs to, and their coalition. So all of this resulted 2 years ago in the passage of our law. And as a few people have said, and I share Len's view on this, our law is very much bipartisan. As I'm going to describe it to you, it's a very odd amalgam of approaches. It kind of has something in it for everyone. We joke that it has something in it that everyone likes and at least one thing in it that everyone hates. So it has, for people kind of on the more progressive end of the spectrum, expansion of government programs. On the other end of the spectrum, we've become the first state in the country to require that people buy health insurance. And the bipartisan nature of the law was really nicely typified, actually, for me at the signing ceremony. And the picture in the middle below the wedding cake is a picture of Governor Romney signing our law. You can see Senator Kennedy in the background. And when he got up to talk about the law, Governor Romney said, Senator Kennedy, I told my son today what I was going to do. And my son looked at me kind of in surprise and said, Dad, you must have found a cure for global warming, because when you and Senator Kennedy are agreeing about a law, hell must have frozen over. And then a couple minutes later, Senator Kennedy got up and he said, it's interesting you were talking to your son this morning. I was talking to mine. And when I told him what I was going to do, my son also looked surprised and said, gee, Dad, when you and Governor Romney agree about a law, I have to assume that one of you hasn't read it. Now, given some of the things that Governor Romney actually subsequently in days said about the law, many of us began to think that that might actually have been true. But in any event, it really did come together through a strange amalgam. We're in the second year, as I told you. I'm a mother of a small child. Since I had my child, I've learned to see everything in child developmental terms. But we sort of had a lot of progress in the kind of infant stage. The law is now turned 2. We're in the toddler years. Whether these will be the terrible 2s or not, I think, remain to be seen. But there are many, I think, very good lessons in our law, and we're making a lot of good progress. And we haven't solved the question of cost, coverage, primary care, disparities in care, any of the other problems that you have heard about today. And whether our law will prove to be viable, either financially or political, over the long run, I think is still very much in question. But we do feel very proud of the progress that we've made. So let me give you a quick overview of the law, and then Brian's going to talk some about what he thinks are some of the lessons for New Jersey. So we started, just to scale this problem, we're a state of about 6 million people, and we had somewhere, we think, between 550 and 600,000 uninsured people. The profile of our uninsured looks very much like it does here in New Jersey, from what I heard today, and also nationally. Most of the people who are uninsured are low and moderate income people. Most of them work. We have a much higher rate of uninsurance among younger people, particularly young men. And so to deal with that picture, we've taken 4 or 5 major approaches to trying to expand coverage. So the first is we have improved the availability of low-cost or subsidized health insurance for people. Through two ways. We expanded our Medicaid program, and we extended the eligibility guidelines for kids, and also brought back onto the Medicaid rolls a variety of people who we had kicked off back in the 4 or 5 years ago when the state had budget problems, as many states did. Then we've created a new program of subsidized health insurance, which we call Commonwealth Care. This is a program that's available for adults up to 3 times the poverty level, so about $31,000 for a single person, $60,000 or so for a family of 4. This is a program that's available for people who are not eligible for Medicaid or who are not eligible for employer-sponsored health insurance. And it is people pay a premium for this on a sliding scale basis, which ranges from about nothing for people at 1.5 times poverty or below, up to about $120 or so for people at higher income. So subsidized health insurance through expansion and creation of new public programs, absolutely a vital portion of our approach. We've also made a number of changes to our private health insurance market, one of which I don't think any other state has tried, which is we have combined the small group and the individual markets. And we did this because like in New Jersey, our small group, our individual market had become very expensive, had become largely a market through which anyone who just couldn't get coverage anywhere else was buying it. Rates were very high. And there was a study done that showed that if we took the 50,000 or so people in our individual market, combined them with the 800,000 people in our small group market, that premiums would go down by about 25%. For individuals, and the impact on small employers would be almost nothing. And so to create and give individuals the advantage of a much larger risk pool, we put them together. We've also created an entity that's called the Health Insurance Connector, and this is a new state agency that I'm actually on the governing board of. The Connector has a number of responsibilities. One is it runs the Commonwealth Care program. And it also, the executive director of it refers to it sometimes as it's the Travelocity of health insurance in Massachusetts. I mean, what he means by this, it's become a distribution mechanism for people to come and, it's organized the market for health insurance so people can come to the Connector. It offers a range of products. It's negotiated lower rates with health insurers, and so it's really a mechanism through which people can buy coverage. Now, like Travelocity isn't the only distribution mechanism, people can still go buy health insurance directly from companies or through brokers, but it's become a much easier way for people to shop and compare for health insurance. We've also given insurers more flexibility to sell some new kinds of products, and these are particularly products that are sold to young adults, and these have lower levels of benefits, but they're much cheaper. And we did this because we know that people who are younger, it's more difficult to get them to buy health insurance, and a lot of that is cost, but some of it is they sometimes think that they're healthy and immortal. And by offering lower cost products, we both wanted to get them covered, but they're also the people whose good experience we want to bring into insurance risk pools in order to make coverage more affordable for others. So that's, and one other thing we did in the insurance market is we require insurers to allow young adults to be covered under their parents' health insurance until they turn 26. And this has actually been a wonderful thing for, not a huge number of people, but again, keeps those people on coverage as well. The most radical part of our law, and I don't use radical in the good or bad way, just I think the most innovative part of our law is the individual mandate. Starting last year, there's a requirement in Massachusetts that for adults who are 18 or above, that they are required to buy health insurance if there is affordable coverage available to them. And I'll show you in a moment how we've defined affordability. But this is a requirement in some other countries, but in no other state in the country. And it has involved some very, very difficult decisions about what kind of coverage do people have to buy, how do we define the term affordable. But it's administered through our tax system. So when we file our taxes in Massachusetts starting last year, so in April of this year, there's a new form we had to fill out. We had to indicate whether we had health insurance or not. If we didn't have health insurance, the state figured out whether we had affordable coverage available to us. And if people had affordable coverage available and they didn't buy it, then they paid what last year was a fairly small tax penalty of $219. Starting for this tax year, that penalty is really ratcheting up, and it could be as high as $900 for some people. Our model is often referred to, and Len had actually used this phrase of shared responsibility. And that is a mantra that we use in Massachusetts to talk about the law, too, that the problem of covering the uninsured is one that we all share collectively. So there's a role for government through the programs I just talked about. There's a role for individuals, but we also imposed a modest responsibility on employers. And employers who have 11 or more workers have to do two things. One is if they don't make a fair and reasonable contribution to health insurance, they have to pay a per full-time worker assessment of $295 a year. And employers also have to make available to their workers, even if they don't contribute to health insurance, what's sometimes referred to as Section 125 plan, which is the ability for people to pay for their health insurance on a pre-tax basis. Now, Brian and I, who've been around a long time in Massachusetts, would be happy to answer questions about why is the assessment only $295, and why did employers get off with such a small amount? It relates in part to what Len had mentioned in the history of our law, and we actually passed a much more extensive employer mandate back in 1988 when Governor Dukakis was running for president, and it passed with, I think, a 2 or 3 vote margin in our legislature, and we watched over the next 4 or 5 years as it was repealed. And so some of that history very much informed it. Len also talked about, I think, a bribe for a transition in health reform, and we have some of that in our law. We increased significantly Medicaid rates, and that was both a recognition that we had a lot of cost shifting going on in our system, but it also was one of the political deals that was made to get a widespread provider agreement on this. So let me just talk a little bit about our individual mandate, because public program expansions, while they're absolutely essential to our law, the ones that we've developed aren't quite as earth-shattering in terms of their innovation as the individual mandate. So as I said, people in Massachusetts now have to buy health insurance if they have affordable coverage available. So this has involved making 2 very difficult policy decisions. The first is, what's the level of insurance that people have to buy in order to satisfy that mandate? And we've had very lively discussions in Massachusetts about what the minimum level of insurance people should have to buy to satisfy this requirement is. In fact, we had a 5-hour hearing just this last Tuesday to hear testimony on some revisions that we're making to that. It's been difficult partly because although this mandate applies to individuals, it has to coexist in a world in which most people get employer coverage. Because of the federal ERISA law, we can't dictate what the type of coverage employers have to offer is, but we have to craft these requirements in a way that's sensitive to what employers do provide. A couple of the most contentious issues we've had to deal with, and this law has had many, many surprises as we've gone along, I think even to those of us who've kind of been involved in health insurance in our state for a long time. The most contentious issue is whether minimum coverage should include prescription drugs. And I think for a lot of us we thought, well, yes, of course it should include prescription drugs. They're such a fundamental piece of and part of healthcare these days. It turns out there are many, many employers in our state who offer coverage who don't cover prescription drugs. So we had a very zesty fight about that, although the final standards do require prescription drug coverage. So the standards were one. And the second is, okay, so what's reasonable to expect people to pay? And the slide that you're looking at shows you what the affordability standard is at the moment in Massachusetts. It's remarkable to me that it fits on one PowerPoint slide. But so as you look at it, as you can see, the standard varies depending on whether you're a single person, a couple, or a family. It varies by income. The affordability schedule for people who make less than 3 times the poverty level is the premium contribution for the Commonwealth Care Program that I talked about. So you can see if you're a single person and you make around less than $15,612, you aren't required to pay anything to health insurance. But that means that if you're eligible for the Commonwealth Care Program, you're required to enroll in it. And so above the red line shows you the premiums for Commonwealth Care. Below the red line shows you the premiums that people are required to pay if they're not eligible for subsidized coverage. So you can see, for example, if you make $40,000 a year, Massachusetts says that if you have coverage available to you that costs you $220 a year or less, you are required to buy it. And so that's how that works. As I said, it's enforced through the tax system. And these are the tax penalties. So the tax penalties are phasing in over time, recognizing that it's very complicated to explain this to people. This is a whole new, really culture for people. So last year the penalties were fairly low. This year they ratchet up, depending on your age, to over $900 a year. A lot of outreach and enrollment and education of people about these new requirements. Much of which has actually focused on younger adults because they proved to be, and this was not a surprise, a particularly difficult group to reach. I just thought I'd show you 2 examples of the kinds of ads that you would have seen in Massachusetts around tax time. Trying to let people both know about the tax penalties and the requirement to buy health insurance, but as you can see, designed in a social marketing way to kind of try to impart to younger people what some of the value for them of buying health insurance would be. I've sat behind the mirror at a lot of focus groups of young men in particular over the last year. And it turns out that all of the reasons that I would like to think would be compelling to them about why they should buy health insurance, it's good for us as a community, just completely don't resonate. Tax penalties resonated, and the other thing that resonated is they had absolutely no idea how much things cost. So we've been doing a lot of marketing which tries to educate people about the cost of getting medical care. Now, the good news about our law, and we have made a lot of progress, is that on the coverage end we're actually doing very, very well. As of March of this year, we have 439,000 newly insured people in our state. Again, this is off of a base of somewhere between 550 and 600,000 uninsured people when the law passed. People have gotten new coverage both through public programs, particularly the Commonwealth Care Program, but also Medicaid increases. About 60% of the newly insured people come through public programs. But there also has been a lot of expansion of coverage in the private market. And I think the number which perhaps has surprised, I would say, me the most, and I think a lot of us, is the number of people who actually have gotten new coverage through their employer plans. So these are people who were eligible for employer coverage, had never picked it up, but now we have to assume as a result of the individual mandate have enrolled in their employer plans, and quite a few new people have also gotten coverage through the individual plans. We also have seen, and this was a big concern, it's always a concern when you expand public programs, a concern, would people drop their private coverage and enroll in the new public programs? That's something that the policy wonks call crowd out. And we have not seen that in Massachusetts. Actually, the percentage of employers offering coverage has stayed very steady. And there's, in polls of people, we don't have any indication that folks are dropping out of their employer coverage. As a result of these gains, we have had a significant drop in our rate of uninsurance, and we have a variety of sources to measure that, but the latest federal data that came out last month showed our rate of uninsurance in Massachusetts is now about 5%, and it's under 3% for children. That gives us the lowest rate of uninsurance in the country. Brian noted this, which I thought was very interesting. As some of you may know, the total number of people without insurance in the country went down last year by about a little over 1 million people. Brian did some math and discovered that 25% of that decline was in Massachusetts, was because of Massachusetts, even though we only account for 2% of the population. So we may be taking your money, but we're, I hope, making some contribution to the decline. We also have some evidence that access is improving for uninsured people and in a whole variety of different areas. I think many of us didn't know how this individual mandate was going to go, and it wasn't clear how it was going to be received by the public. And I think we were wondering, would there be a kind of health reform equivalent of the Boston Tea Party when people found out that there was going to be an individual mandate. And we've seen in a number of our health reform initiatives in the past a lot of a talk show host will get hold of part of it, the public will rise up. So we didn't know if we were going to see, Blue Cross and Blue Shield policies thrown into the Boston Harbor or something, but it turns out that there really was widespread compliance with the individual mandate. Most people filed over 3 million tax filings, and what we discovered on that was the vast majority of people had health insurance. About 5% of people who filed didn't. There were 97,000 people who were deemed eligible to buy insurance but paid the penalty instead. Then there were about 62,000 people who couldn't afford health insurance based on that schedule. 9,000 people claimed a religious exemption. People, for example, who are Christian Scientists or belong to other religious groups who don't believe in health insurance or don't want to buy health insurance are exempt. So really widespread compliance. And we've seen a significant drop in hospital charity care, which is one of the important ways in which we're financing this law. About 2/3 of the financing comes from redirecting money that's already in our system away from direct payments to providers to giving health insurance to individuals. And that seems to be working as well. And as well, public support for the law, which since it was enacted has been very strong, has actually increased since the different provisions of the law have gone into effect, including the individual mandate. So in terms of extensions in coverage, public support, the coalition that supported it hanging together, and the beginning of some evidence of improvements in access, those are all good things. As you heard from some of the people who've preceded me, we face some challenges, and not surprisingly, financing has been one of them. Although I'd have to say the immediate financing challenge really we have weathered very, very well, and so it's not as if we're capping enrollments or anything like that. The major financing problem we've had is that people have enrolled in greater numbers and more quickly in our Commonwealth Care program, and so what we had predicted the program would cost and when it would cost, that amount has happened more quickly. The actual cost per person enrolling in the program has been exactly what we predicted. And we have made some changes in cost sharing in the program and some increases in terms of what people are required to pay. We've also just passed in the last couple of months a new financing package which has imposed some new obligations on insurers, hospitals, and employers to help fund the law. We're in the process of renegotiating our waiver with the federal government at the moment, and because a lot of the money that helps to fund this law comes from the federal government, that's a very important renegotiation, although the signs are very good that the federal government's going to continue to support it. Our biggest challenge is the one that faces us as a country, which is really this one, and healthcare costs. And our approach, very deliberately in Massachusetts, and we can argue about this, was that we wanted to do coverage first. I completely agree with what everyone has said about coverage and costs and quality being inextricably linked. But our approach was, let's cover people first. And so the first version of our law had virtually nothing in it about costs. In fact, because of the Medicaid increases and some other components, it probably was cost enhancing. But we know that the long-term sustainability of the law depends on controlling costs. And since the law was passed, and particularly with the coverage expansions, we have really the beginning of what we call round 2 of health reform in Massachusetts, which is a very serious and robust beginning of a discussion on costs. Our legislature passed a cost containment bill a couple of months ago, and it doesn't have any magic solutions in it. There's really nothing radical in it, nothing that I think is likely to make a huge difference in the short term. But I would argue that we're having in Massachusetts right now, largely as a result of our coverage expansions, one of the more robust cost conversations in the country. So we are definitely a work in progress, and we are definitely an experiment. We feel very good about the coverage gains that we've made. We're the only state that has really made a significant expansion in coverage in the last few years. I agree with Dr. Emanuel and some other people this morning. This is not a problem that states are going to solve by themselves. Even rich states, which start with good preconditions like Massachusetts, and ERISA is going to increasingly, I think, prove to be a big complication for us. But we are making a difference, and I think it's important that states, if you look at the history of policymaking in our country, states have always led the way on big social reform. So our law is definitely doing that. It's making an enormous difference in the everyday life and the financial security for the 400,000 people who've gotten coverage. And I think we're learning some very interesting policy lessons as we go along, and definitely some political lessons as well. So one thing that has very much been in the minds of people in Massachusetts since the law passed was how much people are paying attention to our law. We can't do anything without it. It seems appearing on the front page of the Wall Street Journal and the New York Times. There is a lot of pressure and responsibility people in Massachusetts feel not to let our law fail, because we really do believe, at least until we see what the election results are, that if our law really takes a terrible dive, that will set back the discussion on coverage in the country, and we feel that responsibility. So, and we hope we're giving some momentum to conversations in New Jersey and other states and across the country to dealing with this terrible, shameful state in our country of how many people don't have health coverage. So, Brian, I think, is going to talk a little bit about what he thinks some of the specific lessons are for Massachusetts, for you and other states as well.
I would love that picture. I want to leave it up. I think it's so cool. So thanks again for inviting me. So my name is Brian Rossman. I work at an advocacy group called Healthcare for All. We organized a broad coalition to support passage of the Massachusetts bill. The coalition included hospitals, included the medical society, included community groups. We had a big religious coalition of dozens and dozens of churches and synagogues. And in fact, the God factor was very important in the political back and forth, having some of the ministers go and rabbis say, you got to pass this, it's what God wants. And so that's what we worked on. And I'm here really to give some lessons, I think, for New Jersey that I think are applicable to New Jersey, but also to be a little bit like Nancy, a cheerleader for Massachusetts. The negative stuff that you're hearing has been exaggerated greatly. We're actually doing quite well considering, I guess, is my main message. So I have 5 lessons that I want to go through pretty quickly, and then one sort of other stuff to think about that I'll mention. So lesson number one, is the process of passing the bill affects the implementation. What happened in Massachusetts is there was a lot of back and forth, and you had the business community, and you had us advocacy community, and the hospitals on every side. In the end, they reached a consensus in that picture of Kennedy and Romney coming together to sign the bill together was very important in setting the standard for the implementation that came afterwards. And in the implementation process, it's never smooth, it's never easy. Nancy sits on this connector board. There's been enormous pressure in this connector board that has a business and a labor and a consumer and an insurer to find consensus. And there are 10 members on this board. They've never had a 9-to-1 vote. They've never had an 8-2 vote. I mean, they've never had a 5-5 vote. They've never had a 6-4. Once or twice they've had a 9-1. But they almost always find almost unanimity, or they find absolute unanimity. And that's, I think, the political passage process influences the implementation. And that's something important to keep in mind for all the interest groups involved, that if you push too hard, you're going to get it screwed later on in the process. So that's number one. Number two, I want to talk about affordability as the key pressure valve. I think a lot of the critique of Massachusetts is that it's not universal coverage, and the answer is that's right. It is not universal coverage. Because they added this important affordability exemption, you saw it was about 62,000 people in the first go-around. What we told the people, and there's been polling on this, people were scared. You have to buy health insurance. Oh my God, what if I can't afford it? Well, the government says, well, if you can't afford it, we'll leave you alone for now. You're going to be okay. And in fact, that very complicated affordability schedule, on top of that, there's a waiver process. You fill out a form, you explain, I had a problem, I was taking care of my elderly mother, and we had 2 kids, or my husband lost his job and my income looked high. But you could get out of the requirement, get out of the penalty, if you have a good reason. And the governor said we're going to be very compassionate with this individual waiver process. And I think that smoothed over a lot of the initial concerns. So think about how to build in, as you move towards covering more people, you know, it doesn't have to be universal. I think making major improvements is worth the fight. Affordability is number 2. Number 3, we want to worry a lot about underinsurance as much as uninsurance. And that's another important lesson that Nancy talked about. The state is setting, if the state says everybody has to have insurance, we have to say, how much insurance do you have to have? How much is the minimum? And this is tough. And so this fight over drug coverage is one area. The fight over what are the most deductibles, what are the highest copays that people are expected to pay. Should primary care, should preventive measures be required pre-deductible? That's something that Massachusetts has required. This underinsurance problem is very important. And it relates to affordability. Remember, you can't solve the uninsurance problem just by shifting costs onto people who don't have the capacity to pay. So you have to worry about underinsurance as well. So that's number 3. Number 4 is this funding issue. Nancy mentioned that charity care spending has gone down considerably, but the cost of the program is a lot more than what we're saving in charity care. And that's the way it works in real life. You can't claim the uninsured are getting lots of expensive, mostly emergency room care, and by getting rid of that, you're going to make their lives better and you're going to save a lot of money, but not nearly enough to cover people. So you can't pretend that you can do this without some new spending. And either you get a new revenue source or you just say we're going to spend the money. In Massachusetts, we're basically doing both. We've just appropriated more for health care because we say it's a priority, and we have this new revenue sources, some of these new assessments and shared responsibility things. So number 4, charity care isn't enough. And finally, number 5, and I think this is the most interesting thing. You know, when Toyota builds cars, they're famous for what they call the continuous improvement process. Along the assembly line, if something can be fixed, they're always making changes along the way. The same thing is happening with health reform in Massachusetts. We passed this law April 2006. The implementation has continually been adjusted along the way as we see how things are going. The legislature has passed 3 bills since, technical corrections bills, making adjustments here and there, changing terms. There was a whole assessment that after it passed on businesses called the free rider surcharge, they just got rid of virtually all the way. They just decided this isn't going to work in real life, and they just eliminated it. So that we have this process, the regulations defining minimum coverage are being phased in over time. The penalties are being phased in over time. Every year they revisit the penalties. So don't think you have to get it perfect at the front, because you have chances and opportunities to fix it, and this feedback loop is very important. So you're never done. And I guess for us as an advocacy group, that's what we're learning. This is, what they say, a life sentence without parole. Once we pass this bill, we as an organization, we're so good at getting senators and representatives to say, vote yes on 1, 2, 3, 4, vote no on Senate 5, 6, 7. This implementation stuff is really complex. It happens in a lot of places, and it takes a lot of public attention. So there are these groupies that go to her connector board meetings. There's about 60 people. Most of them are paid to be there, but not all of them. And it's the hospitals and the health centers and the doctors and the advocates and the religious group coalition and all these various groups are watching every step of the process and having input. So those are my 5 lessons for New Jersey. Then I have an addendum. I came up with 3 Ds. Okay, 3 Ds, things that we did not do. Well, things that I think have to be part of the mix that are a lot tougher and just to sort of think about. Number 1, I would put on D. Number 1 is dental coverage. Dental coverage is, for historical crazy reasons, is not considered part of medical care in the United States of America, and all the evidence suggests that dental care is absolutely critical to overall health. They're now finding links to stroke and heart disease, low birth weight babies, and we don't include dental care as required coverage in Massachusetts. For the Commonwealth Care Plan, only the people below poverty get dental care. This is a major hole in the thing, and it's tough, it's expensive, and no one feels an entitlement to dental care. It's like an add-on, and yet it's part of keeping people healthy, and so that's D number 1. D number 2, we just mentioned briefly before, is disparities. So even insured people with the equal insurance and equal incomes, yet the evidence is real clear that ethnic and racial minorities get less care, different care, poor outcomes. This is not solvable by easy money, and it's a deep societal issues. There are very important social constructs here at work, but to ignore that problem will mean that we're not moving forward on the health agenda. We have to deal with racial and ethnic health disparities. My final D is, I've sort of alluded to before, is just do it. As you know, I think as the state of New Jersey is looking at the federal debate and what they can do, I think it's important for New Jersey to just go ahead and take that leap. You don't have to get it perfect. I think what we need to do is what Uwe talked about, is Altman's law. Stuart Altman used to be my boss, and remember his law that Uwe mentioned, that every interest group says that if I don't get my way, I prefer the status quo as my second choice. And since blocking is easier than passage, usually nothing happens. The key lesson of Massachusetts is that something is possible. And I think that's more important than any policy detail, from Nancy's slides about how affordability and mandates and all that stuff. It is possible and real for the left and the right, the employers and the advocates, the hospitals and the doctors, to find a way to give up their preferred solution. Nobody in Massachusetts got everything they wanted, and reach agreement on something that's workable, and they continue to work at it. And so I'm feeling like things are going quite well, and I look forward to answering questions about specifics in Massachusetts. Thank you.
Well, it is a great pleasure to be here. I'll have to say that I've spent a lot of time in the great state of New Jersey. Wasn't that long ago that my youngest daughter last year just graduated with her graduate degree from a little institution right down the road called Rutgers University. So I spent a fair amount of time up here. I've paid your taxes. I've learned how to negotiate the jug handles. And I've even gotten somewhat used to letting people fill my gas tank when I rent a car. So I almost feel like a native. I am the designated dark cloud here who's going to rain on the parade. You were just talking about the fact that you presented the optimistic view of this. I'm going to make it a little more negative. This is a very dark road people are going down. There are a lot of pitfalls. There's a lot of turns in the road, and Massachusetts has made it down the road, but as Nancy has mentioned, they're not all the way down the road. It's still a work in progress. So I'm going to point out some of the problems that you're likely to encounter in doing this. First off, states are limited to what they can do on health care reform. They're limited for several reasons. One is Medicare. Medicare is federal law. All the seniors under Medicare, you really can't do much with those seniors. You've got Medicaid, that is federal state law. New Jersey can ask the federal government to give them a little bit of a leeway or something, flexibility. Sometimes they give it, sometimes they don't. But you're limited because of Medicaid. S-CHIP. New Jersey wanted to move S-CHIP up to, I think, 400% of poverty, didn't you? And the Bush administration came out and said, no, we're not going to let you do that. Can't do it unless you can prove 95% of the children under 200% of poverty have coverage. Those are all limitations on what you can do about health care reform. And as Nancy mentioned, there's ERISA out there, Employment Retirement Income Security Act. Large employers, and for those of you who aren't that familiar with the way the health insurance market works, there's the individual market where people go out and buy their own health insurance policies. That's 17, 18 million people. There's the group market. We generally divide it into the small group market. We talk about 2 to 50. Those aren't solid numbers, but roughly 2 to 50 for the small group market. Those usually buy health insurance regulated by the states. Large groups tend to self-insure under ERISA. They come under federal law. The federal courts have been fairly particular about what states can do in insinuating themselves inside ERISA plans. And frequently states have tried to do that, and the states have come up, and the federal government has come up and said no. One recent example, Maryland not long ago, the legislature passed what was called the Walmart bill. It was called the Walmart bill because it required all large businesses, I think if I remember right, over 10,000 employees. They had to be private sector. That exempted Johns Hopkins. They had to be private sector, and they had to pay. They had to either provide health insurance or pay, I think, 8.5% of their payroll into a state fund. That was filed under that was challenged under ERISA. And the federal court upheld that. The state legislature said, we'll come back and we'll redo this and make it pass the ERISA test, but they haven't done that. Typically, states that have gotten too involved in the large group market end up bumping up against ERISA. So far, and that's been actually a question why that has not happened in Massachusetts, there has been an ERISA challenge to the San Francisco legislation to try to create sort of a universal coverage inside the city of San Francisco. Here is a Boston Globe article titled, this is from the 6th of this month, State Could Be Sued, Healthcare Giant Warrants. The state, we don't know what happens with ERISA yet. It hasn't been challenged, but it has to be challenged by someone, and it may be that it is in the near future. Anyway, the point being is it's very, very hard for states to create some kind of universal coverage there. About all you can really do, apart from federal law being changed, is try to figure out some way to pick up the pieces. And Massachusetts has done a good job of trying to do that so far. Second problem you got. Reform proponents always oversell the benefits and undersell the cost. When they're talking about it, you will find that proponents of it generally always say, if we do this, we're going to have all these people covered, and generally they'll say it's either going to cost us very little or not cost us anything at all. Now, there is a graveyard filled with states that tried to pass some kind of plan like that and eventually found that it died. Oklahoma did this back in the early 90s. They were going to pass a plan, create an Oklahoma Health Care Authority. They were going to start out with their Medicaid population, then they were going to move to the uninsured population, and then they were going to move and cover everybody under Sooner Care. They started out with Medicaid, found out that was costing more than they thought they were going to have to pay. Providers began to drop out. They began to cut the reimbursement rates. Eventually, the whole thing just sort of fell apart. Tennessee is sort of one of the biggest examples. Tennessee created TennCare, a grandiose plan to try to cover all the Medicaid and uninsured population, and with the hope of moving on to cover everyone once they proved that managed care was going to save them so much money that they could provide care for everyone for the same money that they were spending with all the uninsured they had. Well, Tennessee struggled for 15 years trying to pay for that thing. Tennessee doesn't have an income tax. They looked at passing an income tax. They looked at various things to try to do to make the thing affordable. Here just a few years ago, Governor Bredesen, a Democrat, simply said, we can't afford this anymore. We got to end TennCare. They were looking initially at dropping like 325,000 or so people off the rolls. And the governor, when they decided to move that direction, didn't even really initially create a stopgap measure for those people, which I was surprised. I think he's come up and done that. But TennCare, something they tried to do, couldn't make it affordable. Maine is one of the most recent examples. Maine created Dirigo Health. That was supposed to be the solution for everyone. And it became, from the media and others, here's the model, everybody look at Dirigo, this is going to be the way we're going to solve the problem. It wasn't going to cost anything. We're going to be able to cover all the uninsured. When they started out, they anticipated covering 130,000 Mainers by 2009. That would be in 3 or 4 months. And as I said, they wasn't going to cost anything. They now have about 12,000 people covered. Only 5,000 of those had been previously uninsured. The rest of them had coverage, and they moved over into the Dirigo plan. They spent $164 million on the program, and they're looking at a $20 million budget shortfall right now. The governor has closed the plan until they address the budget issues. Nobody's talking about Maine being a model for the future. So you do have these problems, and other states have tried things. New Jersey tried your legislation back in 92, 93, guaranteed issue community access, community rating, everybody gets to move into the plan, pay the same price. Senator Vitale has mentioned some of the problems of that. I was around back then working on health policy. We talked about the problems it was going to create and the cost increases it was going to implement in your state. You are now one of, if not the most expensive health insurance state in the country. We sponsored a website for several years that we had up, and we asked the proverbial question, what's cheaper in the state of New Jersey, to get for a family to get a health insurance policy or to lease a Ferrari? We put the prices of Ferrari leases and your health insurance off your state website on there. You could lease a Ferrari for less than you could buy a family health insurance policy. Friends, as we say in Texas, when you can get a Ferrari for less than health insurance, you done screwed up somewhere. So that needs to be addressed. Third thing, you know the comment where we say Rome wasn't built in a day, Rome wasn't destroyed in a day either. And it oftentimes takes a little while for these policies, these new plans, for the cracks to begin to emerge. Almost all of them look pretty good from that first year or two. Massachusetts, and I will agree, looks pretty good. They've done a good job of getting people covered, but a few cracks are beginning to emerge. What do you see when this starts to happen? Let me tell you a few things. Cost will start rising faster than anticipated. This gets back to the overselling of the benefits and underselling the cost. Cost starts rising pretty fast, and then the state has to address how are we going to deal with these costs. Almost none of them ever address it from what an economist would do. Remember, our problem with health insurance, it's an economic problem. Health insurance insulates people from the cost of care. The more you insulate people from the cost of something, the more they tend to want to consume of that product. And the issue has always been, how do you find some kind of balance where people have coverage in case there's a major accident, major illness, major bills are coming in, they have coverage, and yet there's a reason for them to find value for their health care dollar. If you simply take people and say, you walk into the hospital, you walk into the doctor's office, you walk in the pharmacy, you get whatever you need, it's going to be covered, you have no incentive for people to be value-conscious shoppers in the healthcare marketplace like we are in every other sector of the economy. So, once you insulate people, Lynn mentioned about technology driving up price. There's a part of that there. I would argue that the vast majority of the reason for the cost increases in health insurance is the fact that people are insulated from the cost of it. Just imagine, if you could get a Lexus for a $15 copay, what would happen to the demand for Lexus, and what could Lexus turn around and do about its price? With all that demand, we can raise our prices. You would see all the same things happening there. Number two, special interests get involved. Now, I don't use special interest as a pejorative, but they do get involved here, and they want to have their various elements covered in the plans. They want to have podiatrists, chiropractors, nurse midwives, everything you can imagine they want covered in the plans. A lot of times with good reason. One of the things that my organization does, and you can get this on the website, on our website, we track all the state mandates, all the health insurance mandates. We track them for every state. We put an actuarial estimate on the cost of them. By our estimate, there's 1,901 state mandates out there. About 40 or 50 in each state, where the state says you've got to cover this, you've got to provide this. It was mentioned New Jersey moved up to, or Massachusetts moved up to 26, I think, on your legislation for covering people. We call that the slacker mandate. Kids who don't get out of the house, they're still on the family's health insurance policy. slacker mandate. Now, insurance, they price it for kids 2 to 18. That's the healthiest segment of the population. If you go to college, you stay there to 22, insurance says that's fine, we'll let you own there. You go to graduate school, 23, 24, that's fine. Once you hit about 25, most of them want you off because you're no longer being priced, you no longer cost what it does to charge for a kid. You're an adult, you have more expenses there. If you let kids stay on there till they get older, you're going to ultimately force that charge for kids to grow because you're no longer just looking at that 2 to 18 population. Incidentally, I think New Jersey just went up to 31. We had always said that if you get past 30, you're no longer in the slacker mandate, you're in the loser mandate. Look for them to move to 35 sometime soon. The point is, ladies and gentlemen, that special interests get involved in this and they want their stuff covered. And that makes health insurance policies more comprehensive, which is good. That's what most of us want. It also makes them more expensive. And you start pricing people out of the market when you get those policies too expensive. So you got to be careful about what you do there. But the political interests are to try to cover as much as possible. And it is my understanding that that is going on right now in Massachusetts as more of the consumer groups and so forth are saying you've got to cover autism, you've got to cover this, you've got to cover that, making those policies more expensive. Third, you always see the cost-cutting measures. Once the prices get too high, then the state has to come and say, all right, what are we going to do about cutting these costs? How are we going to do it? There's several ways to do it. They could cut reimbursements to providers. I just brought a couple more articles here from the Globe. These things are appearing here. This one is health provider predicts big loss. Hospital Alliance cites impact of reform law. Could cut 300 jobs, suffer $25 million shortfall. According to the hospital, he says, we used to get our bills covered. Now we're only getting 60 to 70% of what we used to get as they begin lowering reimbursement rates in order to make it affordable. At some point, you start getting to places where providers say, we can't provide it anymore. Dental benefits were mentioned. Dental benefits widen, waiting lines grow. August 7th, 2008, from the Boston Globe. The problem is that just 17% of dentists statewide have been willing to see these newly insured patients despite reforms intended to boost their ranks. Dentists say the state's reimbursement rate for adults covers only about half their cost, and they also cite payment delays and burdensome paperwork. You find this not only in Massachusetts, but in virtually every place where this goes on. It goes on in England. England, an article back in the spring, 2 million Brits unable to get access to a dentist because the reimbursement rates are so low. The point is that you'll start seeing all of these things happening, and Massachusetts may be able to address it. They may not be able to. They're already facing budget shortfalls, $134 million budget shortfall. That has moved the governor to look at new taxes, $45 million on employers, $28 million on hospitals, $33 million on insurers. So insurance is high in Massachusetts, and so we're going to raise taxes on them to make it more affordable. That's what we're going to do. We think providers charge too much, hospitals, so we're going to increase their taxes by $28 million. And $45 million on employers. The employers are stepping up saying, look, since the plan has been implemented, we're spending, I think it is $500 million to cover people in the state. We're doing our fair share. And yet they're being criticized for it. Point being is you had a negotiation which managed to you made a lot of concessions the various groups did to get them all in. Once these pressures start occurring, you start finding groups being peeled off in this, and whether or not this program can stand, we just don't know. Does this mean states can't do anything? No, they can do things. But and let me just say a couple of things about that. I would encourage you as a state, you must understand that people are economic beings. We do make rational economic decisions. And as a result, healthcare reform ought to do things which try to take that into consideration. That is, you need to try to find a way in which you're encouraging people to be value-conscious shoppers in the healthcare marketplace. You need to do things which encourage them to ask, where do I get value for my dollar? If you set the economic incentives right, and most healthcare systems, they're set wrong, but if you set them right, you will find an awful lot of the problems will resolve themselves. Not all of them, but a lot of them. Because it doesn't solve all problems, it doesn't necessarily cover all of the uninsurable people, people with medical conditions, people with low incomes and so forth, so you have to create a safety net that really addresses those problems. We have safety nets right now that we have a lot of people in them who shouldn't be in them, and some people who aren't in them who should be. You got to have a safety net that works right. And then you actually have to let the market work. One of the biggest distinctions between me and a lot of people working in healthcare reform, many of them just don't think markets work in healthcare. I do think markets work in healthcare, but you got to get the incentives and the situation set correctly. And if you do, I think you'll find the vast majority of cases, healthcare will work very well, but you still have to have that safety net. And with that, I'll stop. Thank you.
We have plenty of time for questions, but before we start, I couldn't help but see a little bit of the body language over here. On the right side, or it is the right side. I'm on the wrong side. It is the right side. Nancy, did you, if I can ask Nancy, and maybe Brian can jump in too. Based upon some of the things that Merle said, would you say, well, you didn't read the paper correctly, or you missed the point, or you overemphasized something, or would you say, yeah, they all make sense?
I would start off by saying the Dementors weren't that entertaining in Harry Potter, so thank you. Maybe we can go back and forth on this a bit. I would say to Merrill's first point about federal law being a limitation, that's absolutely the case. And particularly, federal law is a real complication that states have to contend with in doing health reform. And certainly in Massachusetts, we have had to, and we've done this very deliberately, structure and continue to calibrate our law, particularly the employer provisions of it, to try to stay within what's permissible under the federal ERISA law. And I would say to states, though, you can't be cowed by ERISA. You just have to be realistic in terms of what is and isn't permissible. Under ERISA, one reason that I think we haven't been challenged in Massachusetts is because the obligations that we've imposed on employers are really very modest, and they were designed precisely with all of the court precedents and things in mind. So I think you need just to be realistic in terms of what ERISA doesn't allow you to do, notwithstanding that some of the limitations are really very frustrating. On the financing end, and I think Brian can speak to this as well, a lot of the things that people are writing about Massachusetts and the financing are saying that it's costing more than we thought by looking at the original estimates of what the legislature and the governor said it would cost, which I think many of us at the time in Brian's organization was the most vocal on this, always said were not the correct estimates. So the issue isn't what is it costing compared to what did they say it was going to cost the day that the law passed. The issue is what is it costing, and does the state have the ability and the resolve and the will to finance it? And so far in Massachusetts, that's absolutely turned out to be the case. Do you want to add
Yeah, I would just respond real quickly that I think all of the points that were raised have a possible, are one possible path, I guess. And I would go back to what I originally said about the original consensus and the original political will that led to the initial passage and that has sustained the law. There are challenges. Financing is one, benefits is another. These are all big issues. But what we've seen so far, and it can change, no promises for the future, is a resolve by all the political leadership and all the interest group leadership, the kind of stakeholders, to keep the damn thing going because it's better than killing it. The progress is the only way to move forward. And so the state Secretary of Health convenes every 2 weeks this stakeholders meeting, and we go, and the hospitals go, and the business associations go, and we sit and we talk out the problems, and there are issues, and not everybody is always happy, and they get resolved. And so, yes, there's a shortfall because they originally didn't budget enough because the original estimates were lowball, and that was a mistake. And $45 million is coming from employers and $33 from insurers. By the way, the insurer thing, just so you know, is coming from reserves, not from revenue. So we don't think it's going to affect their rates because they don't need to replenish that money. One other point, just on the slacker thing. I love that. I love that name. But I got to say, when I go speaking about the Massachusetts law and I go to middle class groups, this is the best thing we have ever done in the entire state of Massachusetts. They love that their kids, when they come home from college, can stay on their family coverage for, it's just 2 years. They're only allowed to do it for 2 years. Can stay on their parents' plan for 2 years up to age 26. And that's like, I would just win them over when I talk about that. So the parents care about their slacker kids, and so the voters seem to be happy about that. The insurers, by the way, told us again and again there'd be no new cost. They would be able to absorb it.
Yeah. It doesn't cost anything.
Right.
There's
But anyway,
no additional charge.
So the points are good points, but it's all in the implementation.
I understand that the government in Massachusetts is saying that you have to have health care or else.
I think it may not be on. Look at the bottom.
Okay, so I repeat it?
Sorry?
Okay. One of my colleagues and friends, classmates rather, in Massachusetts recently had to give up her practice. Why? Because she could not afford to pay the mandatory health insurance for her staff. Massachusetts says if you don't pay, if you don't have it, you get penalized. Now, she was on the verge of being penalized. Is this true?
So,
Secondly, if health insurance is mandatory, the government is saying you have to have it, there's a penalty. That's my understanding. This is a very serious problem when the government is mandating health insurance with the or else attached to it.
So two things to distinguish. The requirement on employers and the requirement on individuals. Employers don't have to offer health insurance. They don't have to, but there is a penalty if they don't. But the penalty is basically symbolic. It's $300 per worker per year. It's a gentle nudge, but we think it's important. The symbolism, actually, I don't want to dismiss. The symbolism is pretty important. We're saying to all employers you have to at least offer halfway decent coverage. And if you don't, you got to pay this $300 fine. But it's not enough to, I don't think anyone goes out of business by $300 per person. If they're on that verge, I think their business model may not be, sustainable. Well, if they have a staff of 10, it's $3,000 a year. The other thing is the requirement on individuals. And there's an affordability scale built in, like we explained. So, and the requirement on individuals has an out. There's a waiver process. So even under the affordability schedule, if it doesn't apply to you, you can say, I really can't afford it, and hopefully you'll get out of it. I thought there would be enormous backlash April 15th. We talked about the Boston Tea Party. It didn't happen. So far, we don't know. So far, people are okay with this. So far it's working. But it's... Yeah, nothing to do with
socialized medicine. Yeah.
First, my name is Elizabeth Moody, and I just think today's program was absolutely wonderful. I think the speakers we've had were fantastic, and I have to applaud Massachusetts for being so inventive and so creative and trying this. I just really, really applaud you. The one question I have is for Brian. On your 3Ds, in the area of disparities, and this may seem like a simplistic question, But I'm wondering, and we've talked in meetings about this because access to health care is a big issue here in New Jersey, but is there an identifier for those people that are in the lower socioeconomic class level that can be recognized by the health care providers and those that work with them, such as different color insurance cards, different, things like that, that could identify that class level immediately upon seeking services? Because you did mention that was a problem, the services.
Yeah, the disparities issue is not a social economic status. We're talking about blacks, Hispanics, and Asians getting different levels of care, even with identical insurance. And the answers are really complex. There are no easy answers at all. I mean, we don't know the answer, to be honest. But it needs to be addressed by government at all levels, I think. So that doesn't relate.
You have to forgive me because I'm not a healthcare person, and I don't even know how I feel about the concept of universal healthcare. But Dr. Matthews, is it? I have no idea what you're saying, other than I heard a whole bunch of attacks, but I'm not really sure what your point was, or what you're trying to get us to understand, or who you represent. So what's the bottom line that you're trying to tell us we should be doing instead of what other people are telling us?
The bottom line that I was trying to make is that comprehensive health insurance reform at a state level is very difficult, and there are a lot of pitfalls there. And I tried to point out some of them that you're seeing, and you may well see in the near future in Massachusetts. But I wasn't actually asked to spend much time developing what we thought would be a comprehensive health insurance plan. We actually have on our website at cahi.org an 8-point plan that we identify various things. But I can say, and I can probably mention this since Lynn mentioned earlier, I think John McCain with Doug Holtz-Aiken, his health care reform plan, we generally like the tax credits, but there's several things about McCain's plan we would move in that direction. But generally, it works like this. The question is, does a market work in health insurance or does it not? And if you think it does, you generally are going to follow something like what McCain is proposing. If you don't think it does, you're going to be following something like what Senator Obama is proposing. And we think markets work, so we like fewer regulations. We want lots of choice and options out there. We don't want the state or the federal government saying, you have to do this, you have to have health insurance, here's what the policy has to look like, it has to cost this much. We'd much rather have the market work in that. No. In fact, I suspect a number of insurers under an Obama-type plan will do very well, probably the largest, because they envision using many of the insurers that are out there in the marketplace now. So I suspect that some of the insurers would do well. I don't know that it's good health policy, but I think some of the insurers would do well under that.
Yes. My question is more for our esteemed moderators. I don't know about anybody else, but I sure would be interested in being able to get a copy of your PowerPoint presentations. Will that be made available to us?
In about a week or so, 2 weeks, we'll put it all up on our Policy Research Institute website. So the telecast will be there. And then we will ultimately put out a book on this proceedings.
Dr. Matthews, you talk about the consumer being a true economic animal. Are you looking toward various levels of copay so that the insurance then becomes essentially catastrophic insurance rather than the basic means of paying for health problems?
It's a good question. Where the market is moving right now, but both from employers and insurers, is to try to move to something that is a higher deductible account where in many cases people have money either through a health reimbursement arrangement or through a health savings account. For those of you who aren't familiar with this, I just sort of the summary of that is, instead of giving, say, $10,000 to an insurance company to cover you for the year for a family policy, you might give the insurance company $7,000 or something like that for a high deductible policy, maybe $3,000 deductible policy, but you take part of that money, maybe $2,500, put it into an account. The money belongs to the individual. They take it and they use it, so they have that money to pay for it. When they go to the doctor, when they go to the pharmacy, they're using money out of that tax-free account. And this goes to an issue that I had mentioned earlier, the struggle, the policy challenge is, how do you find a way to have people covered and yet encourage them to be value-conscious shoppers? And the health reimbursement arrangements, the health savings accounts are about the best way we figured out to do it. And there may be a better way, but we haven't come up with it yet, which provides money for people to be able to go to the doctor, go to the hospital, but yet it gives them an incentive to ask the question, doctor, is a generic drug just as good as a brand name? Because this is coming out of my health savings account and I want to make sure I get value for my money. That's the missing ingredient in the system right now.
I just wanted to, on the Massachusetts side, if you stay in this game long enough, you heard, actually, I think the Commissioner of Health said, you know, the devil's in the details. And actually, one of the...
God is in the details.
God is in the
God.
No, God is in the essentials, not the details. Remember, just get the essentials. But actually, that prompted me to ask you this question, really about the sort of constant tinkering needed.
Yeah.
I mean, it seems to me one of the possibilities is to say, don't worry so much about the details. Especially the details that are going to split apart your coalition. Worry about the implementation. That really, the devil is in the implementation and not in the details. And that actually, that is a very different message, I think, for policymakers to think about. That you don't just pass this thing, walk away, come back 10 years later and look at it, but that you are going to be constantly legislating on it, and therefore, it's not the end of the road the moment you've passed this bill.
Well, and I think that's one of the very wise things in our law is that it deferred a lot of the very difficult decisions to the implementation process. It set up good structures to make the decisions. It ensured that the decision-making group, the connector and others, had broad representation. It got the essentials right, but it didn't get into the details. And we've seen both through the deliberations on the implementation and the need to go back and make corrective actions. We're discovering new things all the time. We get some of them right and some of them wrong, and then we realize we have to address something else. So I think that's exactly the right point. Get the basic structure right and give yourself enough flexibility to go back and deal with the mistakes that you're invariably going to make.